Hi, everyone. Thank you for joining us today. I'm Jen Schunger from the New Jersey Autism Center of Excellence, which is funded in part by the New Jersey Governor's Council for the Medical Research and Treatments of Autism and by the New Jersey Department of Health. I am so honored to be here today with Dr. Christina Nicolaidis. As a general internist and health services researcher, Dr. Nicolaidis uses participatory research to improve the health and healthcare of marginalized populations. The majority of her current projects focus on autism in adulthood. She's the co-founder and co-director of the Academic Autism Spectrum Partnership in Research and Education, otherwise known as AASPIRE, which is an international academic community partnership that uses community-based participatory research to address the priorities of autistic adults. She's also the founding editor-in-chief of a peer-reviewed journal, Autism and Adulthood. She directs the Social Determinants of Health initiative, which brings together individuals from Portland State University, Oregon Health and Science University, community organizations, governmental agencies, and local health systems to improve health equity. Dr. Nicolaidis teaches research methods in the School of Social Work at Portland State University and teaches and practices internal medicine at Oregon Health and Science University. Dr. Nicolaidis will discuss lessons learned from leading the Academic Autism Spectrum Partnership in Research and Education, which we'll just refer to as ASPIRE, whose efforts conduct rigorous, inclusive research with and about autistic adults. She'll discuss practical strategies for addressing human subjects' concerns, collecting survey and qualitative data from autistic adults, and authentically including autistic adults as part of a research team. I'm going to go over some brief housekeeping notes in a minute, but first, welcome, Dr. Nicolaidis. I'm so happy that you're here with us. Okay, so just the housekeeping notes that I mentioned. If anyone would like to ask a question, which we definitely encourage, you'll just have to be logged into your YouTube account so that you can submit the question in the chat. We will monitor the chat throughout the talk, and we will have some time for Q&A at the end of the session. The session will be available to watch at any time after it ends. You can find it here on our YouTube channel. We will also be sharing it on social media and through our email lists as well. So I'm going to go off camera now while Dr. Nicolaidis presents, and then I will be back for the Q&A. Thank you so much, Dr. Nicolaidis.
So thank you so much for having me speak today. As the large cohort of children who were diagnosed with autism in the late 1990s and early 2000s enters adulthood, there seems to be a sudden panic in the autism world about transition to adulthood. I have to admit, there's this little snarky part of me that's like, who could have ever predicted that autistic kids would grow up to be autistic adults? But I'm still grateful for the newly increased attention to issues affecting adults on the spectrum. Now, I could easily spend the next hour talking about the challenges of transitioning to adulthood and the dearth of services for autistic adults. In fact, I'll be back next month talking about our work to address the significant healthcare disparities experienced by autistic adults. But today I'd like to focus on a different transition, the transition that autism researchers have to make to be able to effectively include autistic adults in research. In pediatric research, investigators need to get children to tolerate research procedures, but they usually interact with the mostly neurotypical parents to obtain informed consent, complete surveys, or participate in interviews. As children transition to adulthood, they gradually play a larger and larger role in offering their own data. Sure, there may be times where you want to triangulate data from other sources, but by the time neurotypical people are adults, we pretty much expect to collect most patient report data directly from the subject of the research. Unfortunately, that's not the case with a lot of autism research. While it's true that some autistic adults may not be able to directly participate in research, even with our absolute best efforts to provide accommodations and supports, there is a marked overuse of proxy report. My favorite are studies where researchers ask parents of, quote, high-functioning autistic young adults about their intimate relationships or their knowledge or interest in sex ed. I mean, seriously, how many of you had parents who could provide accurate data on your intimate relationships when you were young adults? And then we often have the opposite extreme. I can't count the number of autism studies that use survey instruments that have been psychometrically tested in general populations or with parents of autistic children, but don't bother to assess whether they are valid for use with autistic participants or adapt them to make them accessible to a wider range of autistic adults. It's not just survey research either. Actually, the study that prompted my colleague Dora Raymaker and me to start doing our own autism research was an fMRI study whose procedures clearly didn't take into account how autistic adults think or interpret language. And finally, by not getting necessary guidance from autistic adults, researchers run the risk of designing interventions that target the wrong mechanisms of action or aim to achieve outcomes that don't actually match autistic adults' priorities. Ultimately, by not paying sufficient attention to the inclusion of autistic adults in research, we run the risk of getting bad data, which leads to the wrong conclusions, which ultimately leads to ineffective efforts. As researchers and clinicians, we all devote a huge amount of time, energy, passion to our work, and we all do it because we want to make a positive impact. My hope today is to convince you that effectively and ethically including autistic adults in research is critical to making our research have a true positive impact, and to give you some practical tips on how to make inclusion actually happen. Before I go any further, I want to make a note about my use of language, since I've probably already upset some of you. Ideally, we would all use person-centered language, where we ask each individual what they prefer and respect their wishes. But obviously, that's not possible in a presentation when speaking about groups of people. As such, I use identity-first language when talking about autistic adults, based on the very strong preferences of my community partners. I do still use person-first language when talking about people with intellectual disability, again, based on my community partners' preference. Given the ongoing language controversies in the broader disability community, I'll just alternate between the two when talking about disability in general. Today, I'm going to talk about including autistic adults in research, both as study participants and as co-researchers. That's because I find it really hard to effectively include a wide range of autistic adults as research participants without also including autistic people on my research teams. The way I see it, it's like doing research on Latinx health issues, which I did in the past, without a bilingual, bicultural collaborator on my team. I happen to speak some Spanish, and even if I didn't, some English-speaking Latinx people would do just fine taking part in a study that was not culturally tailored or translated into Spanish. But without the right collaborators, I am likely to leave out important parts of the population. I would run the risk of collecting bad data or inadvertently offending participants, and I'd miss out on the expertise that comes from my colleagues' lived experience. It's the same for autism. Over the past 2 decades, I've learned a thing or two about autism, both as a family member, a clinician, and as an autism researcher, but I would never take for granted what my autistic team members contribute to the research. Now, of course, including autistic adults in research as study participants or co-researchers is only a small little piece of the overall story. Ultimately, we need to have autistic adults setting research agendas and priorities, like the autistic members of the IACC, making funding decisions, conducting research, both as insider researchers like my own collaborators, Dora Raymaker, Stephen Kapp, or as community members of the research team, which is what we're going to be talking about largely today with the rest of the community partners on the AASPIRE team. And then developing interventions and programs, shaping the literature, which we're doing with my new journal, and disseminating findings outside of academia, and simply just setting policy. My participatory research groups have been working to authentically include autistic adults in research since 2006. Last year, we conducted an institutional ethnography of this work, reviewing study artifacts and team member experiences from 3 closely related collaborations that had performed multiple separate mixed method studies with autistic adults and adults with intellectual disability. The main collaboration involved is AASPIRE, or the Academic Autism Spectrum Partnership in Research and Education. This is a long-standing national and now international community academic partnership that conducts participatory research with and about autistic adults in order to meet community priorities. I co-founded AASPIRE in 2006 with Dora Raymaker, who at the time was an autistic community leader, but now has transitioned over to the dark side and is an autistic scientist herself. You'll be hearing from her soon in an upcoming talk. We use a community-based participatory research approach where academic and community members serve as equal partners throughout every phase of the research. Our team includes about a dozen autistic adults with very diverse characteristics, as well as other stakeholders. Over the years, we've conducted multiple quantitative, qualitative, and mixed methods projects on healthcare, employment, burnout, and outcomes. And I do want to thank the NIH for their longstanding history of continuous AASPIRE support. And though I'm supposed to be talking about inclusion today, I do want to take a quick break and point out our ASPIRE Healthcare Toolkit. The free publicly available toolkit is divided into information for patients and supporters and information for providers. We designed the toolkit knowing that each and every patient has their own strengths, needs, and preferences, and that adult providers can never possibly learn everything there is to know about autism. The centerpiece of the toolkit is the Autism Healthcare Accommodations Tool, or AHAT, which creates a personalized accommodations report for busy healthcare providers. The point is to allow patients to communicate clear, actionable information to providers about the accommodations and strategies that will facilitate their care. You can also find a host of accessible information, checklists, and worksheets to help patients navigate the health system or manage their health. We co-created these materials with our autistic partners to make sure that we covered the most important topics and did so in a very detailed, practical, and accessible way. I'll be giving a talk focused on our healthcare studies in November, and we'll talk more about this then. Okay, back to inclusion. The second partnership was the Partnering Project. This was a CDC-funded observational study led by my colleague, Dr. Rosemary Hughes at the University of Montana. The objective was to assess the relationship between violence, health, and disability in people with developmental disabilities. But as you can imagine, proxy reporting is particularly fraught when asking about experiences of violence, abuse, or neglect. As such, we again used a CBPR approach to create a way to anonymously collect data directly from people with developmental disabilities. The third partnership was the Pregnancy, Disability, and Women's Decisions Project. This was a qualitative study about the pregnancy experiences of people with intellectual disability and autistic people. Unlike the other two partnerships, this study did not attempt to use a full CBPR model, but we had an advisory committee of people with intellectual disability and autistic adults. We used findings to create a series of 8 videos as resources and are currently applying for larger funding to create an online pregnancy decision aid. I bring this project up because as much as I absolutely love and believe in CBPR, I don't mean to say that every project has to have a complete full CBPR approach. Now let's talk about what we've learned and our recommendations for including autistic adults as study participants. People are very often coming to me asking me questions about human subjects protections. There's a really important and critical tension here. We really need to avoid undue risk, the risk of undue influence and exploitation. This is critical. At the same time, though, we also want to maximize autonomy and inclusion. Preventing people from making their own decisions is just as unethical as having them make decisions when they actually don't have the capacity to do so. One thing I would say is don't assume that anyone with an autism diagnosis needs to go assessment of decisional capacity. It's actually rather offensive. What we do is we try to consider the level of risk and the types of decisions participants make on a regular basis. So for a low risk, for example, internet survey, when people are directly accessing it themselves over the internet, we make the argument that they're probably making much riskier and much more difficult choices than what we do with our survey. When decisional capacity is unclear, which often it is, especially in some of our in-person studies, I would consider a brief comprehension assessment after an accessible informed consent process. And again, if somebody doesn't have the capacity to make their own decisions, that doesn't mean they get completely left out of the process. We still encourage supported decision-making and of course, getting assent when possible. So I mentioned the idea of after an accessible informed consent process. This is actually really important. We've worked with our community partners to co-create materials to try to make the consent process as accessible and as inclusive as it possibly can be. Um, you can create clear, simplified consent forms. Most institutions have all sorts of gobbledygook in their consent templates and these warnings that say you're not allowed to change the boilerplate text. That's a lie. You actually are. You just need to make a good argument for why it actually is impeding the ability for people to give informed consent to use that language. We've worked with our community partners to really transform our consent materials to try to make them more accessible. We use a question and answer format, visual aids, white space, things to try to make it as possible for people to understand and then be able to show that they have decisional capacity. We also have worked hard to reduce participant burden. For example, at first we were being told that no, you need to have written consent. But the burden of having an autistic adult take the consent form, print it out, sign it, scan it, do it with some other, is actually so high that it becomes a barrier to their right to participate in research. So we've often worked with our institutional review boards to try to make this as streamlined as possible so that can in fact have the opportunity. And then of course, doesn't have to be on their own. We often we often offer people the opportunity to take time to discuss anything they wish with a trusted person. A few of our sample consent forms and other materials are available on our website if anybody wants to use them as guides. Now, I'm going to talk as a mixed methods researcher. I can almost always see the utility of combining qualitative and quantitative data to fully understand what's happening and what can be done about it. However, qualitative data collection can be tricky with autistic adults who often say they have challenges with open-ended questions. Our community partners, again, have helped us develop a host of strategies for rich data collection, including allowing participants to have an advanced look at study materials and the use of prefaces to help participants better understand what's wanted. We strongly suggest offering synchronous and asynchronous modes of participation with both oral and text-based options to allow for different accommodation needs. Again, we were originally told, oh, you can't do that, you can't combine the methods. We found that it's actually much more important to collect the data in people's preferred mode. And we've gotten very similar data across modes. And then, of course, it's really important to provide enough specificity and concreteness. And that's where I work with my community partners, because I'm often thinking I'm asking a question that's perfectly specific and concrete, but it isn't. Now, again, some people can answer very abstract questions. Some people can answer very vague questions, but we've found that we've been able to really broaden the range of people who can take part in our qualitative studies by paying close attention to how we collect our data. Survey studies can also be tricky. As I mentioned earlier, I'm constantly amazed by how often autism researchers use validated instruments that have not actually been psychometrically tested with autistic adults. When we've reviewed survey instruments with our autistic community partners, they have found most existing instruments to be inaccessible. Partners often felt that if taking a survey that used these instruments, they would experience confusion, frustration, anxiety, or anger. They repeatedly stated that faced with such measures, they would offer unreliable answers, leave items blank, or just stop participating in the study. That is not what we want as researchers. Over the years, we created and refined a collaborative measurement adaptation process where academics work closely with community members. The collaboration part here is key and takes work. I'll talk more about that later. It's important to include community partners with varying disability characteristics, to pay close attention to accommodations, and to provide partners with accessible trainings on basic science concepts. Ultimately, academic and community partners make all major decisions jointly using a formal consensus process. For each construct, we present the Community Council with available measures and summarize existing data. And then we collaboratively decide which ones to use, and we assess the need for any adaptations. And of course, we always reassess the psychometric properties since these are new adapted scales. Common community partner concerns have included the use of difficult vocabulary, confusing terms, imprecise language, figures of speech, complex sentence structure, and convoluted phrasings. Partners struggled with response options that used vague terms. They also felt anxious if their answer might not be completely accurate or if their responses could vary in different situations. Often the surveys did not completely capture the intended idea. Sometimes instruments used offensive language or ideas, and in some cases, there just weren't any instruments to measure what they thought was important. We've worked together with community partners, item by item, to address their concerns. Common adaptations have included adding prefaces to increase precision or explain context, modifying items to simplify sentence structure, substituting difficult vocabulary words, confusing terms, or figures of speech with more straightforward terms, adding hot links that define problematic terms or offer examples or clarifications, adding graphics to increase clarity of response options, and adding new items related to autism-specific aspects of the construct. Here are just some examples where a simple substitution could help make items easier to answer. And here's an example of how our group handled vague response options. As you can imagine, having to choose between options such as a little of the time versus some of the time felt like torture to many of our autistic partners. However, when they suggested adding precision by specifying things like 20% of the time, some of our partners with intellectual disabilities felt that that would increase their anxiety as they did not feel comfortable with percentages and math. Our group came to consensus by adding these graphics of cylinders filled to a different degree. We have found that these types of adaptations can allow many participants who normally would have a hard time reporting directly to take part in research studies, either independently or with some help from a supporter. However, that's not always possible. We recommend using proxy reporters only if direct participation is not possible, even with accommodations and supports. It's important to distinguish a supported participant, where an autistic individual answers questions with help from a supporter, from a proxy reporter, where it's the supporter who's answering questions with minimal input from the individual. We've created separate surveys for use by proxies. We review and adapt all the items, focusing on what the proxy reporter can answer on behalf of the patient versus where the proxy reporter can only provide their own perspective. We also make sure to provide a way for supporters to offer their own opinions separately from the person they are supporting. Our processes have yielded a number of newer adapted instruments to measure health, healthcare, and social issues. We're more than happy to share any of these instruments. Please just contact us. Despite all this work, there's so much that still needs to be done. What are the most important outcomes to measure when evaluating services for autistic adults, and how can we best measure them? I'm very excited about an NIMH-funded R01 award that we started this February. It uses ASPIRE's longstanding CBPR approach with the addition of a few new academic and community partners to create what we are calling the AutProm Toolbox, a set of accessible patient-reported outcome measures for use with autistic adults. And then we plan to test the toolbox in real-world settings where services are likely to be delivered. The plan after such testing is to make these measures widely available to researchers and service providers. We have three major steps to creating the toolbox. First, we're currently using a modified Delphi process to select the most important outcomes to measure when evaluating services for autistic adults and to identify instruments to include in the toolbox. The Delphi panel consists of 30 autism researchers, service system leaders, and community leaders. We started with 60 outcomes identified by our full ASPIRE community academic team. We're now in the middle of 4 rounds where the full ASPIRE team uses input from the Delphi panel to decide which outcomes and instruments to include. Our team will then use our CBPR process to adapt instruments as needed with permission from owners. And then we will do cognitive interviewing and pilot test all the instruments. In the last 3 years of the project, we'll test the toolbox in a cohort of 750 autistic adults with 3 subcohorts recruited from the health system, the disability services system, and the community. We'll psychometrically test the instruments, offer expected distributions of the measures in each subcohort, and assess responsiveness to change and factors predicting change. So, up to now, I've been casually mentioning all the wonderful contributions that our autistic partners have made to the research. I hope I've convinced you of the benefit of including autistic adults on the research team. But the truth is that authentic collaboration doesn't just happen without a lot of thought and effort. So, I have a bunch of recommendations. First is to be really transparent about your partnership goals and approach. Not all participatory research is the same. It's really important to think about whether you're striving for an equal partnership the way we do with ASPIRE, whether you're trying to authentically include people and collaborate throughout the whole process, or whether you're really just seeking consultation. There's many different approaches, and there's whole alphabet soup of CBPR, PAR, PSC. We can go on and on. Again, there's no one best approach. It's really important to match the context and the goals to the goals of the research. And most importantly, don't pretend to be doing something you're not. I've seen many bad outcomes from partnerships where people thought that they were going to be having a real say and real decision making, shared decision making power, when really they were just being asked to be advisors. If you're going to use people as advisors, make sure they know that and make sure that that's what they're expecting. I've been, again, casually mentioning CBPR, community-based participatory research. Again, this is the approach that we've used both with ASPIRE, the partnering project, and with many other projects prior to my getting involved with autism research. The idea is that the community keeps the research respectful, accessible, and socially relevant, while the academics keep the research scientifically sound and academically relevant. That doesn't mean that people can't trade roles. As I mentioned to you, Dora, who started as our community lead, has now gotten her PhD and is an NIH-funded autism researcher, and I myself wear a community hat as a family member. However, we try to really make sure that we're keeping that community and that academic, those functions really clear. We work together in every phase of the project, and at each time we make sure that we're doing things to be as impactful as possible. So while we're developing research, while we're implementing it, while we're disseminating, we bring in the expertise that comes from lived experience and the expertise that comes from our professional training. Building a community academic team, again, takes some work. And people often come to me asking about how they can start on such an endeavor. The first thing I have to say is treat partners as team members, not as study participants. I've had people come and tell me that they're going to get like a random sample of autistic adults to be on their team. And I'm like, did you go get a random sample of statisticians? Like, we don't do that. What we want to do is create the optimal team for this particular project. It's really important to clearly describe roles and expectations and select partners who can commit to those. We consider the expertise the project needs based on different types of lived experience. Just as I might need a co-investigator who has particular expertise in this content area or this methodology, I'm going to bring in people who have expertise based on different types of lived experience. We also try to create a balance between autistic community leaders and other autistic adults. The community leaders are incredibly important in bringing those connections and understanding the big picture, and really keeping us tied to community values. At the same time, it's also important to bring in autistic individuals who might have a different experience than community leaders. We try to identify partners who have a shared long-term vision and who will prioritize achieving collaborative goals over individual gains. In other words, we really avoid drama. They're going to be people who are going to really work well as part of a team. And yes, autistic people work really well as part of a team. But we do want to make sure that we have people who are really committed to those long-term goals. And then we do include non-autistic partners, but we're very selective to include people who are truly willing to share power with autistic adults and are willing to listen to them, um, and to respect that they're the people who best understand the experience of being on the spectrum. Again, we have lots of materials on our website, including the recruitment materials we've used recently, and our onboarding and our roles and responsibilities documents and things that, again, you're totally welcome to adapt to your own needs. It's really important in this work to create processes for effective communication. I can't emphasize that enough. We spend a lot of time, we just brought on some new partners to our project, and we spent a lot of time identifying individually assessing accommodation needs, then discussing them as a group, and then reassessing them regularly. We also ultimately have to discuss and address competing accommodations. Some of the things that make it easier for some of our partners to participate make it quite hard for other of our partners to participate. This is a challenge, but it's a challenge that can be met with enough thought and attention and will. We always provide meeting materials in advance of meetings. So some of our partners who need extra time to process them, or, for example, one of our partners who uses a letterboard to communicate takes the time to type out to spell out her answers beforehand, which would be very hard to do in the middle of a meeting. We present concepts and information using accessible language and format so that partners can truly make informed decisions. I have to say this is hard. Sometimes a simple email or a set of slides can take me hours in trying to make sure that I've really communicated complex scientific concepts in a truly accessible way in plain language. And then we use email a lot, and we found that having a structured format can really improve clarity. We use a structure where every email starts with headings of purpose, actions, deadline, stipend or compensation, summary, and then we get to the details, and we do the details in Q&A format. Honestly, I actually have started using this format, not just for my autistic partners, but for several of my other professional collaborations, because it really does highlight what actually has to be done and when and why it is you're sending out this email message. We've recently made some big changes to our ASPIRE team meetings. Again, 14 years ago, when we first started meeting, it was very obvious that our autistic partners were not going to be able to participate over telephone conferences. That's what we had at the time. Our group is remote by nature, and between auditory processing issues and other autistic related communication issues, telephone was out of the question. So for over 10 years, we were having all of our meetings exclusively in text-based format. That worked really well for the autistic partners we had on our team. And it didn't work so well for me, which was really good because it made me shut up. And sometimes the best thing we can do as researchers is be quiet. And it was just a lot harder for me to take over with my very verbal way when we were using text-based meetings. As we've expanded the diversity on our research team, we realized that that wouldn't be an accessible way for some of our newer partners to participate, including our partners with co-occurring intellectual disabilities, our partners our partner who used the letterboard, one of our partners is blind. So we've, again, worked really hard to come up with a way that we can all meet together and still respect everybody's individual needs. It's now that we've got it going, it's quite fun. We have this concurrent Zoom video for the people who want videos. We have a professional cart service or captioning in real time for people who have auditory processing issues and would rather read. We always show everything we're talking about. We show in plain language slides that we take great care are accessible. We have a very active chat, but instead of it having just doing it on the side, that happens in a lot of Zoom meetings these days, we make sure that either the facilitator or a monitor reads out loud the chat comments, so that they get integrated in the main conversation. We also have an etiquette for knowing when people are typing a longer response so that we can wait for them, and then for indicating digressions so that we can keep those aside. It's real important to have strong facilitation, a clear agenda. We have some of our undergraduate students help out being a time monitor. I've got my project coordinator being a chat and AV monitor. I really need all these supports to make this happen, but it does happen, and we manage to communicate quite well. We also have to allow adequate time and space for partners to process informations and really make good decisions and contribute to the discussion. Sometimes that takes longer than we expect, and there are times where we just have to postpone sections because we're falling behind. It's more important that we get a good decision, and true collaboration than that we speed through what was on our agenda. Really important to focus on building trust and maintaining trust. Um, I have one bullet here about recognizing and respecting community culture and values. That's because Dora Raymaker, my wonderful ASPIRE co-director, is giving an entire talk on that next week. But this is important. Again, I wouldn't go into Zambia and pretend to be able to do research without understanding the culture. We also need to do that when it comes to autistic culture. We start each project with a visioning exercise, and I find that that's really great. It's really good for both community partners and autistic partners to really hear each other's hopes and dreams, why they want to do this, what's important to them. And often they find out that they actually have a lot more shared um, than they would even think around what's important and why we're spending our time on this. We do all sorts of little get to know you activities and icebreakers. I find that those really make a difference for us to bond as a team. They always sound corny, but they work pretty well. And then it's real important to just actively listen. Demonstrate that you value the lived experience. Don't just write off what people say. And with that comes following through and implementing group decisions. I can do all of the we get together, we talk, if we don't actually follow through and do the things that we as a team have decided, then none of this matters. We regularly report on progress. We celebrate the successes, make room for humor. Again, this is supposed to be fun. And I love our collaborators. And then we regularly evaluate the collaboration. So again, CBPR in particular is based on this idea of equal power sharing. That's easier said than done. As academics and as neurotypical researchers, we just have so much privilege. But again, with thought and with care and with effort and with feedback loops, we can get there. We've jointly created publication and presentation guidelines. Again, they're on our website if anyone wants to model off of them. And we process for making decisions that I'll talk about in a moment. I'd say just really think about the role that power and privilege may play in tensions between academic and community partners, and actively work to equalize power. And one thing that comes into play more with autism than when I've done CBPR with other marginalized groups is there's this tendency for people to pathologize the tension. Oh, it's because the autistic partners are too rigid. Oh, it's because the autistic partners don't have good communication skills. And I would say, think about it when you're having those thoughts, because honestly, there are tensions in every CBPR partnership, even when we're talking about completely different groups. And I would say, really stand back from pathologizing the behavior to figuring out what's causing the conflict and figuring out how to address it. So I mentioned that we use a structured consensus process. I love this. Again, I don't even know where I learned this. I learned this probably 25 years ago, and we've adapted it along the way. But what we do is we have our normal discussions. And then when it comes time to making a decision, we don't just sort of assume that people have agreed. What we do is we call for fingers. And what these fingers are is, one finger is I love it, two is it's fine, three is I have more questions. And of course, then what are those questions? Four is I don't like it, but I won't block it. And again, why? And five is I dislike it so much I can't live with it. What often happens is a variety of different things. One, um, people are talking and or typing and talking, whatever, going on and on and on, when really we've already all agreed. We're all at a one or a two. We can just make our decision and keep moving. Sometimes it's the opposite. We think we've made a decision, and people have actually stayed quiet, have not participated, but they're not ready to go along with it. And that's where having that opportunity to give a three or a four or a five is really key. The first time around, if anybody gives a three, four, or five, we generate new ideas. We try to address it, and we call for fingers again. The second time around, if somebody is giving it a four, that means that they're okay with it and will continue. I'm going to give you an example of when we did this. Example comes from the partnering project I mentioned, of where we, on this meta level, when we first introduced the idea of our five-finger process to our partnering project team, we talked about it. It seemed really obvious. It seemed everybody was like agreeing that we should do it. We called for fingers, and one woman with an intellectual disability who hadn't said a word during this discussion gave it a four. And it was kind of like, whoa, okay, why a four? And what she just said was that showing fingers was childish, and she didn't like it because it made her, it was childish. Well, for somebody who's been infantilized their entire life, you've got this 60-year-old woman who's been infantilized her whole entire life, this is a problem. And it's a really easy to fix problem. On the second round, we said, oh, okay, well, but how about instead of showing fingers, we just say the number? She gave it a one. That's the type of thing that if we had voted on it, we would have just passed it, and she would have been annoyed by this for years to come. By giving people that opportunity, we can often make little fixes and improve it. Sometimes people tell me, but you're letting people have a five. One person can veto your entire thing. And I'm like, yeah, because if one person on my team feels strongly enough to veto it, then I don't want to do it, because chances are there's going to be problems down the line. Now, this only works when you have a team that truly has trust and collaboration, and we have a joint vision and we're working together. I wouldn't suggest using a five-finger process with our Senate right now, but for these teams, I really do want us to reach consensus. And it's amazing how well we get to consensus and how often we just tweak things so much for the better because of things that come out during our five-finger process. Then it's important to collaboratively disseminate findings. Figure out a way to present findings to minimize stigma and harm. I am appalled at how often the autism literature just uses really pathologizing, really stigmatizing, really dehumanizing language. That's just not acceptable. And again, I would hope our group wouldn't do that anyway. But again, working with community partners can really make sure that we avoid ableist and dehumanizing language. We include our community partners as co-authors on scientific papers. I've done this even before. This includes our partners with intellectual disabilities. This includes, in my other projects, partners who don't even speak English. People are like, well, how can they be authors on a scientific paper? They can. If you look at the authorship requirements of the International Organization of Medical Journal of Medical Journal Editors, or whatever the organization is, you need to have contributed to the design of the project or the analysis or interpretation of the data, which our partners certainly do. You need to have either contributed to the writing or the revision of the manuscript for content, and you need to have approved the final version. What we do is we make sure that people have a way to contribute content and to approve the final version. Sometimes we do that with a lay translation table where we take each paragraph and we have the scientific language on one side and then a lay explanation on the other side. Sometimes when it's the language is fairly accessible to begin with, we just put in little comments with explanations for some of the more, excuse me, technical language. And then at times we might meet either individually or in groups with our community partners to really make sure that they've had a chance to contribute for content and to approve the paper. We also work with our collaborators to create, to co-create lay language briefs. And most importantly, we jointly find ways to use the findings to advance community priorities or goals. And then we encourage community members to find creative venues for dissemination. Oftentimes, they're actually much better at getting the word out than I am with my middle-aged, poor understanding of social media and everything else. I'm sorry. So it's also important, one of the principles of CBPR is to actively encourage community capacitation. We've tried really hard from the beginning to offer opportunities for autistic individuals to pursue educational opportunities, participate in internships, or serve as research staff. As I mentioned, my own co-director went from being a community partner to getting her PhD using our AASPIRE, as part of our AASPIRE work, and has really transitioned into an amazing into being an amazing scientist. We've also had other people who aren't even interested in academia gain work skills by being research assistants on our team. This is really important, and I absolutely am committed to increasing the number of autistic researchers, just as I'm committed to increasing the number of Black and Brown researchers. This is all extremely important for our science. That being said, be really aware of the inherent power differentials between faculty and students, trainees, and staff members. And as much as I try to, really promote community capacitation into academia, those individuals can't substitute for collaborations with autistic individuals, organizations, or leaders that you don't have power over. We've really worked hard to always make sure that we have a large team of autistic adults that aren't necessarily my students or my employees. I mentioned earlier that it's important to evaluate the process. We mean well, and we try really hard, but you need that constant feedback to really make sure that you're collaborating the best as possible. We do this in a variety of ways. We have a quick little keep change exercise at the end of every meeting where we just simply ask, what should we keep from today's meeting? What should we change? And we constantly are making little tweaks based off of really quick little feedback that comes at the end of meetings. We've often just very recently set up a way that people can provide anonymous feedback really any time they want through a standing online survey. And then we have kind of deeper check-in discussions and interviews at project milestones or when there's been a change, when we really want to take more thought and effort in evaluating how things are going and getting deeper lessons from it. At times in our projects, we've often had either internal or external formal evaluations as needed, depending on the project. Ultimately, the goal is to build a culture of trust, learning, forgiveness, and continuous adaptation. And that culture is key to really working as a team. Everybody knows that we're a learning organization. and that we're going to be constantly striving to do better. That also means that when we make a mistake, it's okay. When our community partners make a mistake, it's okay. When I make a mistake, it's okay. As long as we're doing this and learning from it and changing and making sure that we're constantly doing better. There's the Maya Angelou quote of, um, you know, do your best until you know better and then do better. And I feel like we really need to apply that with our research collaborations. I also wanted to just mention about compensating partners. This is a big issue. We get paid and we get paid fairly well to do our work. It's also important to compensate community partners on the team. It might not always be possible in the planning stages, especially for junior researchers. I know I certainly, when I started, that was very difficult, but make it clear that you will compensate partners when there's any funding. For small grants, it can be fairly small stipends. For larger grants, we make sure to include funding for community agencies and salary support of autistic individuals. Basically, if you have money for participants, materials, or staff, you have money for partners. And then be creative. You know, the first study we did, we didn't have any funding for. Again, I know I have an incredible amount of privilege, but I just worked a few extra clinics and you know, I covered for some people, worked a few extra clinical shifts, and instead of getting paid, asked my university to create a little fund. And we were able to pay stipends to our community partners off of that fund until I was able to secure external funding. So I can't help it, but I have to also mention our new journal, because inclusion in research goes beyond just what happens on your research team. I was given this incredible opportunity now about 2 years ago to be editor-in-chief of a new journal on autism in adulthood. The journal focuses on the most pressing issues affecting autistic adults from emerging adulthood into later life. I'm the editor-in-chief, and Dora is my associate editor. When Marianne Liebert Publishers originally contacted me asking me if I wanted to be editor-in-chief of a brand new journal in autism in adulthood, I said, okay, but if we do this, we're going to do this really differently. And, you know, I have to say, our publishers have been extremely open and supportive of us kind of stretching the boundaries of what we can do as a peer review journal. We have 10 autistic adults on our editorial board, as well as many family members and clinicians, and of course, many well-established academic researchers. People sometimes wear multiple hats. We also have a policy where each manuscript gets a traditional scientific peer review by at least 2 scientific peer reviewers. May or may not be autistic, but you know, realistically, most of them are not autistic these days. And it gets a review by an autistic adult. And this autistic review really focuses on, is this important? Does this matter? Is this respectful? Does this use a strength-based approach, or is this pathologizing? What's gonna actually come out of this? How will this study actually affect autistic adults either now or in the future? I was floored. Within 3 days of putting out a request for autistic reviewers, I got over 200 autistic volunteers to review, and they've done a lovely job, often really offering important insights that have helped authors revise their papers to be much stronger. We also have an insight section in each issue for personal perspectives of autistic adults. And I have to, at the end of our first year, I went back and counted, and I was really proud of us. Out of 45 articles, 15 of them included at least one autistic author or co-author. If you think about the autistic inclusion in the rest of the autism literature, I would guess it's probably like point of something percent. We're just wrapping up volume 2. In fact, right after this talk, I have to go and send in the final pieces. And then we're going to be starting our third volume in 2021. Certainly, if any of you are doing autism research, please consider submitting to our journal. And if any of you are interested in reviewing or helping with the journal, please let me know. So I'm almost out of time. I guess the really question for you all is, can or should you use a participatory approach? I'd say it's worth it, obviously, no matter what type of research you do. I mean, I only mostly talked about mixed methods because that's what I do, but you can use participatory approaches with basic science, with experimental or cognitive psychology. Participatory approaches are not tied to a particular method, but you need to decide for yourself. It takes a lot of thought and effort. Are you willing to share power? Do you want to learn from autistic adults? Think about how and when inclusion of autistic or other stakeholders will benefit your work, and think about the level of involvement that's desirable and feasible now or as you work on it into the future. And be transparent about it. Think about who needs to be included. There isn't a cookie cutter approach for all of it. Which autistic types of autistic individuals, caregivers, clinicians, disability professionals, others, who has the power? How are you going to balance that power? What organizations can you partner with? What are the benefits or downsides with working with a particular organization that may or may not share your values? How will you ensure that partners are authentically engaged? And think about how to avoid tokenism, breaking trust, or pretending that you're doing something you're not doing. Please avoid that. That ultimately hurts all of us. And, go for it. It's okay to make mistakes. It's okay to not be perfect. It's incredibly rewarding to include autistic individuals, again, both as research participants and even more so as your team members. So I wanted to point out again, we have a lot of resources on the internet. We have our collaboration toolkit that has all sorts of our collaboration materials and samples. We have our healthcare toolkit that I'll be talking about more next month. And I mentioned our pregnancy resources that came out of that smaller project. A big thank you to the AASPIRE team and to the Partnering Project team. And obviously to our funders, especially again, the NIH that's been consistently with us for over a decade now. I will take questions.
Okay, I'm back too. We're gonna check and see if we have any questions. In the meantime, I want to tell you that as a parent myself who has experienced this whole process, I too know the firsthand, the types of research and the information that's prioritized, the language that's used, everything that researchers do affects societal attitudes, and interventions and therapies that get decided. And when you were presenting, one of the things that was really like a parallel that I saw was like this inclusive participatory method is really aligned with like children having IEPs or individual education plans, and the need for individualized support and accommodations in order to participate, having these universally designed tools that can be adapted as needed for each person. And so this really is all about accessibility, and it matters in the labs just as much as it matters everywhere else. And even the long-term implications of thinking about informed consent, autonomy, and self-determination, and even supported decision making, having researchers almost help empowering autistic people and their families to think about these things is going to help everyone to be as supported as possible. So I really thank you for all of your expertise in this, and your own lived experiences have obviously influenced this too. It's really wonderful. Um, okay, so let's see here. One person wanted to make sure that either the slides or recording would be available. So we'll definitely make um, the presentation will be available. It will stay on our YouTube page. It can be accessed at any time. Dr. Nicolaidis might share it as well, and it will, be available to everyone. Um, so another question is, thank you so much for your presentation. What is your view on including adults who are self-diagnosed with ASD in research? Great question.
I think that's a really important question. Um, we know that a lot of autistic adults are not diagnosed. There are. I'm not going to waste your time telling you all the reasons why we have a ton of autistic adults who are not formally diagnosed. I think part of what happens is we we have to think about what's the research trying to do. If you're doing a cognitive science experiment where you're really trying to figure out the difference between an autistic brain and a non autistic brain, it's really important to make sure that we haven't misclassified people. And in those, I can understand why it would be very important to really have very strict criteria of who's who, because that's an integral part of that research question.
Mhm.
For the types of research I do very pragmatic real world research where we're largely trying to improve services, improve, quality of life for autistic individuals. There, I think the good science, this isn't like, oh, because this is, the better science is to include the people that would be included for that particular service or question.
Right.
So, for example, in our new RO1, again, I was told, oh my gosh, NIH will never allow it if you don't kind of follow these rules. Well, those rules aren't the right rules for different research questions. Um, in our study, what we argued, and thankfully our NIH reviewers agreed, is that we want to develop tools that work for each setting. So in the healthcare setting, if the healthcare system were going to do something with autistic adults, they would pull medical records of who's got a medical diagnosis in their charts. Going and doing an ADOS and trying to figure out if this person's autistic or not is not going to happen in the healthcare system. So if we do our own inclusion exclusion criteria and do it by what we think is right, where we don't even know that the ADOS even works for adults. But like if we were to do this, we wouldn't actually be matching what happens. Same thing with the disability services system. Disability services system, they have their own way of determining, their eligibility. Having us as researchers come in and say that our research methods are what we're doing, well, but then their services are going to be for the people that they enroll. So for that cohort, we're enrolling people who have a services diagnosis of autism. In the broader community is filled with people who are self diagnosed.
Right.
And again, if I were to limit to just people who've got a formal medical diagnosis and only do my research with those people, then I wouldn't be able to help the broader community. So what we've done in our project is we actually have different eligibility criteria for our three subcohorts because we purposefully are trying to get a population that matches who would be served in those various contexts. Again, I respect that other types of research may very much need these kind of very clean ways of figuring out how you're classifying your people, but that would be bad science in my field.
Yeah. I think that's such an important distinction is, um, are the people you're studying going to be benefited by, what that research is on? And like as a family, one question that I've learned to kind of ask is, okay, are the people in this study like my child? And is the outcome applicable to her? if they aren't? And these are important questions that, have to be considered. Um, let me just see here. Someone else wrote, um, your way of doing things is a breath of fresh air. Most of the time, I'm dealing with what feels like an alien social infrastructure that does not provide any orientation, briefings, and no sense. Um, we have another comment that says, thanks for making so many resources available. Do you have any thoughts on including children in community partnerships?
I'm an internist. To me, 60-year-olds are young. Like I'm not the best in terms of personal experience, including children. That being said, I think including especially transition age youth is really, really important. My colleague Dora Raymaker, again, who's going to be giving several of these talks in the coming months. Aside from our Aspire work, she's been involved with a CBPR project with young adults, um, teenagers and young adults with first episode psychosis. Um, she's learned a lot about kind of what needs to be different to engage younger individuals. I think it's certainly possible, beneficial, really, really useful. Um, just as we had, again, I started doing research with communities of color. I learned so much from my work with communities of color, and then I had to
Yeah.
adapt it and figure out what would actually work with the autistic community. I would say that it's absolutely possible, absolutely desirable, and you're going to have to figure out some things, because some of the stuff that I do, I know my children or teenage, now they're as a young and adult, but my offspring, certainly when they were children, would not have been interested and would not
Yeah.
have been engaged. So
Yeah.
again, it's another adaptation process, and it's certainly one that is needed and important, and I'd love to see more people doing it.
Yeah. I wonder, what are your thoughts on how families can make sure they are they have informed consent when children are involved in the research? I mean, it's different than, an adult kind of being able to perhaps provide that more easily through accommodations, but what is your advice to families?
I mean, again, I'm not a pediatric researcher, or a pediatrician. I really, my experience is with adults. That being said, very common in all pediatric research, not just autism research, is the concept of assent. And certainly a parent might be making the consent decision, but we still want assent from the child, maybe not, the 18-month-old, but certainly they have just typical development is to be able to give more and more kind of deeper levels of assent as we go. And certainly for a child that is able to uh, provide assent, that's very important. What we often have is the opposite of assent. And we have the child, or an adult with decisional impairment, who clearly is giving messages that they don't want to do it. I have to say, one of my failures, I still almost want to cry when I think about it, is reading through a transcript of an interview that a research assistant of mine did many years ago, who I clearly had not trained adequately, because she had gotten uh, a consent from the parent of a grown man who did not have decisional capacity, and they were participating in an interview. And it was very obvious reading the transcript that this man was not assenting to this. He really wanted to stop, and he really wanted to go. And you could hear in the transcript the mother coercing him and offering him more gifts if he stays, and it was really quite coercive. And my research assistant should have stopped that moment. I feel terrible that I did not adequately train her to do that. But it's our job to ultimately really look for signs of people not wanting to do something. Now, the kid might not want their vaccines and you're still going to give them the vaccine because you're the parent. And there are things that we do as parents where we override our children's wishes because that's our job as parents. But
Right.
for voluntary participation in research, there's a very different bar than for something that they need in order to stay healthy or in order to treat a medical illness or anything like that. So again, I'd have a very, very low bar for stopping or not doing something with a child that's actively dissenting.
Yeah. That's I really appreciate your vulnerability in talking about that because I it's I think what happens, you talked about, people in positions of power, and so there is, like, power dynamics, in research that happens, and, um, you know, like, I think that some parents who have their children there as well may feel, inadvertently that, they can't stop it if the child is not okay with it. So I just really appreciate your vulnerability in that. And everyone is doing their best, and we all learn from these things, and that's the most important thing here. So thank you for that. um One question I just wanted to ask as well was, um, you talked about how you all already utilize Zoom and CART services and plain language slides. And I wonder, now with COVID, more people are using those tools, perhaps not every tool, but at least Zoom. So it seems like this actually presents a natural opportunity for researchers to maybe be able to more easily pivot to a more participatory approach. Has COVID changed the way that you have done things now?
Yeah, and our timing is so we've been doing Aspire for a long time. We also had the partnering project. We weren't using Zoom, as I mentioned. Well, we were using Zoom, but we were using the text version of the text chat part, which is quite different.
Okay.
Um, and that, as I mentioned, worked really, really well. Would have worked really well, COVID or no COVID, with the partners that were on our team. As we've brought on new partners, is when we've had to really kind of expand our participation modes for the Aspire project. For our partnering project, which was years ago, where we did have, again, a very broad group of partners, including people with intellectual disabilities, again, somebody who was blind, somebody who was deaf, um, autistic and blind, autistic and deaf. There, we weren't using Zoom. And we found that when we were trying to do things remotely, it wasn't working.
Mhm.
So we had in-person meetings in Portland, where I am, Portland, Oregon, and in-person meetings in Montana, where the other half of our project was. And then we would just kind of communicate between the two sites, because even though it feels like, oh, we're taking away power by having two separate meetings and it's the researchers communicating, we found it was much more important to have that high quality discussion that was in person. As we got as we purposefully brought on more people to our Aspire team, not just the partnering team, we knew it had to be remote because well, we're all over the place. Before COVID. What we did have planned was a 2.5 day in-person retreat where we were going to figure this all out. Um, and that didn't happen because of COVID. It was right at the beginning of the pandemic. And that took what would have been 2.5 days and stretched it out over months. And it took a long time to actually work with each person to get them comfortable with Zoom, to get them comfortable with the different pieces. So yes, Zoom is working now really well. And yes, I really want people to think beyond what happens normally in Zoom. Is we're having this conversation verbally. Some people are talking on the side in the
Right.
chat, and there's no actual integration or inclusion. I said, that's what we've worked on, and that's what we've worked on with our partners. It didn't come easily. I mean, it was multiple conversations, multiple tries. We at first wanted to, I mean, captioning, professional captioning costs money. We tried to do it with automatic captioning. That really wasn't good enough for our partners to fully participate. We said we've gone back and forth. It does work. I really would love to see people use remote technologies, but
Yeah.
it's not the remote technologies that make it work. It's the effort that goes into figuring out the accommodations that makes it work.
Yeah.
That's the critical piece,
Yeah.
and that it's possible over remote.
Yes, absolutely. We actually recorded with some people from the Autistic Women and Non-Binary Network recently,
I love that group.
and we haven't aired this one yet, but we talk a lot about the virtual interactions and the kind of like rethinking that some like non-autistic people need to do surrounding how those interactions work and like what what how autistic people were using it prior to many neurotypical people starting to use it, and it's just really interesting. So I love that.
I
We
do have to make a point
yeah.
about that. And again, this has come out a lot. Again, we did a roundtable discussion around COVID for my journal again, and I- you know, several autistic people have made this point that's really well taken. Of for decades they've been asking for accommodations that
Yeah,
they've been told are impossible, and now suddenly they're all possible.
right.
And this is an example of what happens when the dominant group needs something. The hope is that yes, these are accommodations that autistic people have been asking for forever. These are skills that they've developed. In fact, when COVID first hit, Dora, again, my autistic collaborator, actually did a bunch of like informal sessions with a lot of our faculty who were freaking out about how to work remotely and how to work at home, because that's what she does. And she's actually built all sorts of skills and strategies.
Yeah.
So it was really helpful for us to be learning from her, because she already has this down pat. My hope is that as we get out of this eternal um, pandemic, that we don't lose some of those things. And that some of the stuff that we've done that actually is, again, it's the accommodations people have been asking for,
Right.
that we manage to maintain that in the long term.
Yeah, I really hope so too. We have one more question, if that's okay. Okay, so they say for some studies, my boss places a lot of emphasis on characterizing the ASD severity within our samples of autistic young adults. We use SRS parent reports and SRS self report. I find this can be very burdensome for participants. What are your thoughts on characterizing ASD severity, and do you know of a more accessible measure?
Um, I'll take the second question first. Of no, I don't have a really good measure. I can tell you there's a lot of problems, and there's there's kind of two sets of problems in my mind. One is the whole concept of autism severity as a linear spectrum makes no sense.
Mhm.
And just knowing the people that are in my life, the people I work with, the people that I interact with, I don't know where to put them on that line.
Yeah,
Because really we're talking about multiple different axes, and they may have more severe or milder traits on each of these different axes, whether it's need for consistency or adaptive functioning or speech fluency or any of these things.
yeah,
And these things change with the environment, they change with the day, they change with the stress, they change with whether or not we're actually giving people the supports they
right.
need. So I philosophically have a really hard time with coming to measuring something that's going to ultimately be a number on a single linear scale for something that conceptually is just does not fit on a linear scale. Um, the second problem is the offensiveness of some of the items. And I've had our community partners, again, there's times where we've been able to adopt stuff, and there's times where they've kind of been like, no. And we've had trouble with autism severity scales. Um, I would love to. I would love to actually offer an alternative. And right now, I don't have one. I think that would be a love. If there's a researcher out there who wants to take on a project, that would be a really, really needed project. We're for our O1, we're focusing on outcome measures, and we're focusing on the things that services for adults are likely to change. And services for adults should not be trying to change autism severity. So that's not really in our it's not even in our radar, because we're focusing on the things that services can actually impact. So our project is very consciously not focusing on those measures. I do feel somebody should, because I really do feel having a better way to capture this much more complicated concept than a single severity score is really, really important.
Yeah, I agree. And the autistic community has said that functioning labels are harmful. You know, high functioning implies that someone doesn't need supports and their needs get overlooked, and low functioning implies that someone is not capable and they are not presumed competent. And so there's so many issues with the use of those. I hope that they will go down in history as something that was maybe perhaps well meaning at some point, but we got over it. And you know, because any person is going to also have different functioning levels. I mean, all of us, you
Yes.
know, if I have a headache, my functioning level is going to be lower at that time. So, you know, having researchers again think about these things and how they impact the community is such, it's life changing for people. So I hope that like we really all understand the importance of researchers. Um, you know, we need all of you. You're all very important, and we're, you know, we're talking about people who we want to help. So, you know, being conscious of these things is really really important.
This is where I'm going to plug Dora's talk next week. And
Yeah,
again, the concept of learning from the community. I wouldn't have known any of this stuff.
yeah,
Why would I know I was using kind of functioning labels before I learned from the autistic community why they're so problematic. Again, there's nothing inherently wrong with us. We don't
yeah,
necessarily know or understand. And that's where truly, I mean, there's a lot you can learn even if you're not like actively in a collaboration, um, by reading, by by engaging, by seeing. There's just a ton of stuff that truly ends up affecting how I do my research, how I raise my son, how I take care of my patients, um, which I wouldn't know if I didn't listen to autistic adults. And it's just that's the way you learn.
yeah, exactly. I've had the same exact experience, and it has meant so much to me to find researchers who are, you know, working with autistic people, and how incredibly validating for autistic people to have researchers, you know, treating them as equals and important, and you know, validating what they've been saying for years of their lived experience. It really makes me happy and very hopeful. um
And isn't it amazing that that's strange? Like,
yeah.
isn't it amazing that this would like, come on, like
Yeah,
this should be like just given. Like,
yeah,
of course we should, value and respect the people we're trying to serve. Um, it's a it's it I am very, very grateful for your kind words, and it saddens me that that's not just the norm, because it really should be.
yeah, yeah. I think autism is certainly behind um, in a lot of ways as a field, and so hopefully, you know, things are moving forward, and in a few more years, we'll be able to think this was, long, long past history.
Hopefully this will be the refrigerator mothers of
Yes, yes,
that.
exactly. Okay, so I did just want to remind everyone that Dr. Nicolaidis will be back in November. You will be talking then about healthcare for autistic adults, which is another really super important area, very under explored and very over needed. So really looking forward to that. Next Wednesday, we will have Dr. Rainmaker here. She'll be talking about uh, basically like including the needs of the autistic community and research and the the importance of understanding their perspectives. And then she will also be back in November to talk about autistic burnout, which is another really important area. It's very important to the community. And I am just so grateful to both of you. You do amazing work. We're going to put the links in this video description for Aspire, for Autism and Adulthood. And Dr. Nicolaidis, if there's anything else that you want us to put in, like, we're happy to, because the more we can get this information out there, the better.
Great.
But
Well,
thank
thanks
you.
again for having me. I really appreciate it. And
Thank
we'll
you
see
so
you
much.
next month.
Yes, thank you so much. Have a great day, everyone.